saying that this is a surgery that they wait to the very last minute. They simply don't understand the scientific literature that supports the use of this therapy much earlier on. Because again, this is about changing the quality of your life. What does it mean to have 5 more years of great quality of life in your life? How about 10 more years? What is that worth? You know, because once you actually have the surgery, you can't go back in time and get those years back. This is about getting the maximum amount of quality of life while we are here. As I said, there are many studies demonstrating DBS compared to best medical therapy alone in the most prestigious journals that exist on the planet. And in every single one, not exception, there's not a single exception, in every time where they compare deep brain stimulation to just medications alone, the quality of life measures in the DBS group far outstripped the medication alone group. I'm going to just give you one single example. This is a quality of life score for patients undergoing DBS for Parkinson's disease. This are the score changes blue with DBS. This is medication alone. Either the quality of life doesn't change or gets slightly worse over time. DBS clearly has an improvement in your quality of life. Let's talk a little bit about the details of the surgical procedure itself. It's essentially a 2-part procedure where the electrodes are placed first, and then the pacemaker is placed in a separate procedure. I tend to do surgeries in a staged fashion because it's easier on patients. One of my goals is making sure that you go through this process in the least impactful way as possible. I'm not going to candy coat this. Obviously it's surgery, it's a real surgical procedure, but I'm going to do my very, very best to make sure you go through this as easy as humanly possible. The first step is placing a head frame on your head the day of surgery. Hitting these brain targets is like being in Earth orbit and having to take a baseball and hitting, home plate at Yankee Stadium from Earth orbit. So you need a special device to precisely target these brain structures, because if you don't get the DBS lead in the right place, you're not going to see the results that you see in the video. It's really important to know that. I always say to patients, DBS is like real estate. You know how they always say, like, real estate is about location, location, location. And if you have a donut shop and you put it next to the cop station, that's probably a good place for a donut shop to do really well. It's the same concept. We've got to get these leads in the right place. It's so super important. It's not a trivial task, but that's really super important. And then we try to come up with a target that's specific to your disease. Every one of you is presenting with a unique constellation of symptoms. And there are different targets that can treat these different constellation of symptoms that we will assess in your assessment for surgery. As I said, the head frame is placed the day of surgery. It takes about 15 minutes. We do it under local sedation. And even though it looks kind of medieval, we try to keep you smiling throughout the process. The next is placing the DBS electrode itself. It's a multi-stage procedure. As I said, first the lead is placed, and then as a separate procedure, I place the pacemakers. In the original way that we did this operation, we used a process called microelectrorecording, where we listen to individual brain cells to guide us to exactly where to place it. It was a really arduous and very technical task. The good news is that imaging has gotten so much better in the course of my career, where now we really are doing image-guided surgery. It makes the operation much shorter. I think I remember my first DBS surgery that I participated in 1997, and it was 20 hours. 20 hours. No, that was way before the MRI era, basically. And now the operations take about 2 hours to place a DBS lead. So
if you have a DBS, can you get an MRI? There's metal in that.
You can. We'll talk about this question. That's a great question, and we will talk about it. The answer to that is yes. Most of the DBS Implants now are MR compatible to a large degree. Remember I talked to you about individual brain cells? This is the way the old microelectrode recording did. As we inserted an electrode into the brain, we could listen to individual brain cells. They would all have a different pattern of activity that we'd see on the oscilloscope, and you create this very intricate pattern and mapping, and you get the electrode into the right place. But you had to be awake. What? Yeah, you had to be awake because the brain signals that underline these activities doesn't exist in the sleeping state. So you might have Parkinson's disease, but when you go to sleep, you don't have Parkinson's disease anymore. Or when you're asleep, you don't tremor. If you're fully asleep, there's no tremor because the signals that underlie these symptoms, they go to sleep along with you. But if you're using those signals to target these electrodes, you needed a patient to be awake. Now, what's pretty amazing is that the brain, even though it's the source of how we feel the universe, it's like the source of everything that we use to kind of have consciousness, the brain itself does not have any pain receptors, so we can't feel any pain. So you can undergo, once your scalp is numb, you can undergo awake brain surgery without a single bit of pain. It's pretty amazing, but as I said to you, we've largely moved on from this awake type of surgery. And the reason why is because, as I said, the imaging has evolved. So when I started doing the DBS surgery in the late 90s, this was the kind of MRIs that we used. And you can kind of vaguely see these dark, splotchy areas sort of there. Those are the targets that we had to hit for these movement disorders. But as you can see, it's not very distinct. It's hard to see. This is the image that I use today. This is a sequence that I've developed along with physicists in the city. And you can see these dark blotches are now these very, very precisely defined areas in the brain that we can see very easily. And if you can see it, you can hit it much easier. Imaging is getting even better now. And this is the way that we're probably going to be targeting in the next couple of years. We're already beginning this process in our center. So to the left is a flower that is seen through normal human eyes. You know, our eyes are only capable of seeing a certain wavelength of spectrum, right? That's all the wavelength we see. But bees, on the other hand, can see far deeper into the ultraviolet spectrum than we can. And that very same flower to a bee looks like a landing pad with like X marks the spot. It turns out that we can image the brain in a certain way as well, where not only can we look at different structures in the brain, but we can look at the fibers or the wires that connect all the different circuits. And we can begin to develop targets based on this circuitry. And so we're beginning that process as well. So this is really going to open up a real patient-specific targeting for deep brain stimulation.
So in increase they would have a beehive placed into the brain, is that like a reverse combination?
The last part, as I said, is the pacemaker. People always want to know how the wire gets from up here down to the pacemaker unit in the chest. I always say it's like if you ever have to pass wire behind drywall, it's the same process. You put an incision from above and below, you pass a tube, connect the incisions, and you're able to basically thread the wire underneath the skin. Everything is completely implanted. Nobody can see your implant from a casual distance at all. Because it's image guidance, we are using MRI and CT to directly place these leads. Again, the bottom line is that you can be much more asleep during these surgeries. I'd then like to talk a little bit about a technology that some of you might have come across in your travels on the internet. How many people here have come across something called focused ultrasound? Okay, few. Okay, well, you might come across this. So I want to talk a little bit about what focused ultrasound is in the spectrum of deep brain stimulation. So before we had deep brain stimulation, we used to do surgery at these targets, but instead of leaving an electrode, we would burn a tiny little hole in the brain. And believe it or not, burning a tiny little hole in the brain at these various targets would result in a lot of these symptomatic relief that we see with deep brain stimulation. However, once you burn a hole in the brain, you can't unburn it. And so what we created a situation where we would place the electrode, the lesioning electrode in the brain, but before we would burn the hole, because you can't unburn the hole, we would stimulate electrically to make sure we were in the right place. Finally, it took somebody to kind of go, well, wait a minute, why are we burning a hole if we could just leave an electrode, not burn the patient's brain, and just stimulate chronically? And that's how DBS was born. So I find lesions to be a fundamental step backwards in time. You know, yes, lesions can affect the brain, they can be beneficial, but ultimately it's a permanent lesion in the brain. You can't program it, you can't change a lesion, and if there's side effects from a lesion, you have to live with it. You can't program that. With deep brain stimulation, should you develop side effects, we can program it, we can tweak it, and we can minimize those side effects. Technology. There's no hole made in the skull. But I would argue that the invasive part of this procedure is not the incision on the scalp that heals, it's the hole that they burn in your brain. And that's clearly an invasive procedure. So, you know, it was first published very recently in 2013. Yes, there's no hole in the head. It can only be really done on one side right now. We know that lesions from the past, if you burn holes on both sides of the brain, there's a lot of side effects. And as I said, you can't program that. Many patients with either dystonia or Parkinson's have symptoms on both sides of their brain. They have to have both sides treated. So this technology isn't great for them. With regards to tremor, as I said, you can't program it. If there are side effects, you have to live with it. So I really consider this, even though it sounds very, very futuristic, it's fundamentally like a step backwards. What are the complications of the surgery? If you look in the published literature right now, DBS has been done about 150,000, 180,000 times across the world. If you look at the published literature rate, about a 1% risk of stroke or hemorrhage in the brain, 4 to 5% risk of infection, and 6% risk of some hardware-related issues. People sometimes can have speech issues with DBS, but as I said to you, it can be programmed around. Very, very infrequently does it cause a significant problem going forward. I've done about 1,600 implants. I've had a very small hemorrhage rate, infection rate, and hardware rate compared to the literature. I think that it's something that we have seen in the scientific literature. Wherever you get the surgery, I implore you to do it in a place where they do it every week, multiple times a week, because the rate of complications and the efficacy rate is far better in centers that do it multiple times a week than centers that do this once a month or once every 2 months. So wherever you get it done, I implore you to find out how often the center does it. And you know, here in Mount Sinai, we're probably the busiest center in the Northeast, so I want you to consider that as well. What happens after surgery? Programming. As I said to you, it's usually done by a movement disorder neurologist like Dr. Gupta or a nurse practitioner with a doctor or independently. The effects are either seen immediately, which is tremor, generally speaking, Parkinson's, which can take weeks to manifest, and then dystonia can sometimes take months to show the full effects. Patience is a virtue. It will take time, but we will get you there. And then very most importantly, once we remove some of the noxious aspects of your disease, lifestyle management, exercise, do everything you can to make yourself as healthy as possible so that you have the best quality of life. Since I have you here, if you don't mind, I'm just going to make a small pitch as to why you have this done here. Many of you are already Mount Sinai patients, but as I said to you, experience counts. Studies that look at the efficacy and complication rates of deep brain stimulation have all noted that the number of cases is directly related to overall success, making it safer, making it work better, better patient selection. One of the very special things about our center is that we have this huge multidisciplinary team. Neurosurgeons, neurologists, physiologists, radiologists, psychiatrists, all working together to team up to give you the best results. This is a small example of this entire team working together to get you the best results. And then in the future, the other thing that to keep in mind is that Mount Sinai is an academic center. And what does that mean? Well, obviously our primary mission is to take care of you, to make your disease better. But we have actually a secondary goal, and that's to improve the field. And by having your care here, you'll have an opportunity to participate in our clinical studies, and you will help us expand the knowledge and ultimately develop a cure for your disorder. So in conclusion, this is no longer surgery of last resort. All of the data that has been shown objectively, not opinion-based, just pure scientific study, shows that this is not only safe and efficacious, but it should be used in earlier stage patients, and that there is a clear advantage of DBS over medical management alone. This has become a much better operative procedure. It is much shorter. Image guidance has changed the game with regards to this surgery. Shorter OR times, less risky, and more comfortable for you. And that's it.